Let's move on to sarcopenia. S-A-R-C-O-P-E-N-I-A. Sarcopenia comes from the Greek sarco for flesh, penia, lack of. So essentially it means lack of flesh. But specifically in the medical world, when we say sarcopenia, we're talking about lack of muscle, right? This is a muscle issue. So 20 years prior, you really didn't hear much about sarcopenia. It wasn't something that people were interested in. We didn't really discuss it in the medical world. But in the last 10 years, there's been a growing interest in this condition called sarcopenia, so much so that we now have many coalitions that have formed globally to address this issue. So we have things like the European Working Group on Sarcopenia in Older People. That's quite a mouthful. We have the Asian Working Group for Sarcopenia. We have the International Working Group on Sarcopenia. I just noticed they all stress that they are working groups. Like, they want you to know they're working, because, you know, we all know that there are many groups that are not working. So these people are really working hard on sarcopenia, right? Why are they so concerned? Why are they working so hard? Because we know that if you have sarcopenia, then you're at risk for things like falls, osteoporosis, fractures from those falls, right? And you are more frail. You also have, we just said, that muscle is metabolically active tissue. So now you will have more metabolic abnormalities and dysfunction as well. The European Working Group for Sarcopenia in Older People came out with a study that basically showed that sarcopenia is a significant predictor of mortality in community-dwelling older adults. By older adults, they meant age 60 and over. And these are people just in the community, healthy, not, hospital-based, not, from a clinic. Regular community-dwelling adults, age 60 and older. If you find that they have sarcopenia, you know they have higher mortality from all causes, right? 4 times higher risk from all cause for mortality if you have sarcopenia. Right? And that's why they're interested, these groups are interested in sarcopenia. Now, the first thing they have to do is, well, how do we define it? How do we define the sarcopenia? And then, how do we assess it? So muscle mass is generally correlated to muscle strength, right? And these working groups have decided that if we're looking at sarcopenia, we really have to consider muscle mass, how much muscle you have, but we also want to look at the quality, and so we'll have to look at muscle strength and or something called muscle performance, all right? Generally, if you have higher muscle mass, then it's likely that you have more strength. That's the general rule, but that's not always the case. There's this 2021 study from New Zealand by Hiol et al. I hope I'm saying the name correctly, H-I-O-L et al. And basically what they found was that muscle mass is a significant predictor of strength in non-obese adults, but not in obese adults, right? So what we see in obesity is sometimes they may seem to have higher muscle mass, and you think that's a good thing. But the problem is because they also have high fat mass, they have chronic inflammation, and so the muscle quality is poor. They probably have fibrosis and fat in the muscle, so it doesn't work as it normally should. And therefore, even if they have a higher mass, they really don't have correspondingly higher strength or better performance of that muscle, right? Most of the obesity that I see would be sarcopenic obesity. So they have obesity because they have increased fat mass and also dysfunctional fat, but they also have sarcopenia because even if the muscle mass is high, it's not good quality. So that's a condition called sarcopenic obesity. So I told you we have to evaluate strength, performance, and then mass. So strength, you can do. You have these devices you can get over the counter even. The most common one would be something like the hand grip dynamometer, dynamometer, right? And it kind of looks like a handle, and you grip it, and it measures the amount of strength in that grip. In academic environments, research environments, sometimes they use leg extension and leg flexion machines to assess for strength. So that's how you could evaluate strength. For performance, people will often use gait speed. So they'll see how fast someone is able to walk between, one point and another point. Another way to assess performance, I think, is the tug, right? The timed up and go. I like using the tug. Generally, people use tug for risk assessment for falls, but I think it's a great way to look at muscle performance also, muscle functionality. In the timed up and go, essentially, you have someone sit in a chair, leaning back, and then you have a line or something you've marked 10 feet away. And you tell the patient, okay, when I say go, you're going to stand up, walk to that line, turn around, come back and sit down. All right? And the minute you say go, you're timing them. Right? You watch them get up, go to the line, 10 feet away, come back, sit down. That's the timed up and go. You should be able to do it in under 12 seconds. If you are taking longer than 12 seconds, then you essentially failed the tug, right? It's not a good prognosis. So, sometimes you don't even need to actually time the patient. You can just watch them, and they're struggling to get up, and they're struggling to walk that 10 feet, turn around and come back and sit down again. You don't even need to time them sometimes, right? Generally, with the timed up and go, you're assessing also balance, mobility, but you definitely are also assessing the muscle strength. So I like using that because, you catch other things with the timed up and go as well. All right, so that's muscle performance or functionality. And then let's talk about mass. So with mass, you could use CT, you could use MRI. Those are great ways to measure mass. But, as I mentioned in an earlier episode, with CT, there's higher radiation exposure, so it's hard to follow people over time. And both methods are also quite expensive, take up time. You have to, go to special centers to get them done. So I have a DEXA, and it's a great way to assess their lean mass, and that's what I use. Before I actually dive into that, I just want to maybe clarify certain terminology, because oftentimes people will use these terms interchangeably and they're not exactly the same. So we really should just make that clear. You will hear fat-free mass, you will hear lean body mass, and you will hear skeletal muscle mass. Okay, so those are the three things you hear, and they will often seem to be interchangeable, although they really are quite different. The way to think about this is just to think about the compartments involved. How many compartments are actually involved? So let's take fat-free mass, right? Essentially, there's only two compartments. There's fat, right? Fat mass, and everything that is not fat mass. So it's pretty simple. Fat and not fat, right? And the not fat compartment would be made up of, let's see, your bones, organs, tissue, muscle, and also water, right? So that's in that fat-free mass. If you look at lean body mass, right, now you're looking at three compartments. So you have fat mass, you have bone mineral content, and then you have everything else, which is the organs, the tissue, the muscle, and water. Okay, so we just took out the bone mineral content. and that would be lean body mass. Skeletal muscle mass is very specific, as the name implies. It's just skeletal muscle that you need CT, MRI for, and basically you can assess the dry weight of the muscle within a certain segment, within a cut, right, of the imaging, right? So again, not so easy to do, so we don't really use it for clinical practices. Fat-free mass, lean body mass, most commonly used, and because I have DEXA, which can separate out the bone mineral content, we're looking at the lean body mass. The most variable components of lean body mass would be muscle and water, right? Because lean body mass, again, would be the organs, connective tissue, and then you have muscle, the skeletal muscle, and then you have water. And obviously, the component that fluctuates the most would be water, okay? So we have very specific guidelines when someone is coming in to do a DEXA, but I have seen many centers where they just tell people to come in, don't worry about it, yeah, just come in, we'll do your DEXA, right? And no, it's going to make a big difference if you don't prepare well beforehand. So what we tell our patients is make sure you have not eaten or drunk 4 hours prior to your test. I don't want you to eat lunch. I don't want you to eat anything. I don't want you to drink anything 4 hours before your test, because that water component, what you have, the water component in the food, for example, I had a protein shake, yeah, that's going to impact your results. The other thing we want to do is before we do the test, we have them go to the bathroom, empty the bladder. I don't want to be like assessing the pee contents as well, right? So we empty the bladder. Now, whenever I do a test, I'm always thinking about how the circadian rhythm might impact the results. So, I try to get them to come at the same time. It's very, that's not easy to do. That's hard. But if you can have the patient come back at about the same time, if they did it at 3 o'clock the last time in the afternoon, then come back at 3 o'clock, or at least come back in the afternoon and not early morning, right? So you want to just be wary and not vary the time too much. In a premenopausal woman, I will also try to make sure that she's coming back in the same phase of that menstrual cycle, because your fluid status can change depending on where you are in the cycle. So I want to try, again, not always possible, but you want to try your best to get that premenopausal woman to come back in that same phase of the menstrual cycle. So, if you're getting a DEXA somewhere and they just tell you, just come on in and do it, just go by my guidelines and you'll get more accurate results, okay? Because we want to remove as many confounding factors as possible. If you look at the water fluctuations, that could fluctuate within, a half hour, right? If you now down a liter of water or fluids, then that's going to impact the results. So the change there is very fast. When we're looking at muscle, really, it's not going to change that quickly. And I tend to wait months, 2 to 3 months before I get the next DEXA. Because, you go to the gym and I'm not really going to see anything in 3 weeks, realistically. So I tend to wait about 2 to 3 months out before I get the next DEXA.